Next up, there's a speaker who is a leading authority in the field of sport and exercise science with his expertise in musculoskeletal health and injury prevention, as well as his focus on recovery patterns in people with long COVID. He has garnered international recognition. He's a researcher and educator, and he collaborates with the UK government as an expert on COVID-19 issues, among many other things. We will have the opportunity to have a Q&A after his presentation, so please fill in your questions and vote them up. And now, please give a warm welcome to Professor Mark Fahey from University of Derby. Please, the stage is all yours, and give us all you've got.
I'm delighted to be here. It's such a much needed and international event to kind of help shed the light and continue to spread the word and awareness around the limitations and the research that is ongoing in response to long COVID and also ME/CFS. So I'm delighted to be here on behalf of my team. And apologies, I am feeling utterly dreadful today. So if I don't make much sense, my team might argue that is completely normal, but please do feel free to get in touch and I'll provide any clarifications that might be there. But I will do my best to get through it in one piece. Before we begin, I like to make sure that we represent all members of the team and show the collaboration that is required to kind of allow us to have the opportunity to be as successful as we have as a research group. And one of the key things that I'm extremely proud of is that we have lived experience experts right at the heart of our research, informing us in the design, challenging us on the delivery, and ensuring that we answer the questions that are relevant and important to people who are living with long COVID and ME/CFS. So I'm incredibly humbled by the group of people we have and can call the experts because they are the experts. But what I'd also like to do is to take the opportunity to say that we are not against collaboration. We will collaborate with absolutely anybody if we can help collectively move the needle forward in providing ways forward and improving those patient outcomes. And that little space there could be you if you feel that we can offer something or we can work together in any opportunity. So I want to put that call to action out there. If anything you hear through this talk or anything you're aware of from the group that you think could be useful or helpful, or we could add value or simultaneously collaboration, then the door is absolutely open for collaboration. So please do get in touch. Now, having just listened to Todd's talk, and I get on really well with Todd, I know Todd really well, it's great that he's actually covered some of the parts of my talk for me, and that wasn't deliberate. That's completely coincidental, but I think that actually allows me a great opportunity to spend more time talking about how we've been using CPET protocols in addressing and trying to further the understanding of the pathophysiology of long COVID ME/CFS. So where he's added that detail so eloquently in the previous talk, I can basically just glean over that a little bit and kind of get to the more what I consider to be the kind of the updates and the insights from the research that we've been conducting. So I'm going to do that in two parts. I'll quickly reinstate the kind of the CPET aspect, what's that look like. But what I want to get to is how useful CPETs can be in long COVID CFS cohorts, and also the kind of the considerations for the testing, because as Todd rightly outlined in the talks and throughout a number of talks today, there's inherent risks and uncertainties around the role of activity and exercise in long COVID patients and ME/CFS patients, and we need to be able to do that in a way that is safe and informative, but doesn't create harm. And as a group, we spent a considerable amount of time developing a protocol that was submaximal and didn't trigger some of those risk factors that are traditionally associated with the longer or more traditional long-standing protocols of exercise testing. So I want to give some space in the talk to make sure that we consider those challenges and also the ways that we kind of can overcome those, to provide safe and informative research, because I stand by what Todd said in the fact that CPETs can be incredibly useful, but they have to be done well and have to consider the broader implications for the patient who is taking part, and also in most cases providing a lot of their energy envelope for that day. So This is the bit that Todd's already explained, so I don't need to go too much into it. But the CPET, cardiopulmonary exercise test, known in the literature or different circles by different names, but essentially it's looking at the integrated way that the body's systems, physiologic systems, work together to provide exercise. And in layman's terms, it's the way of measuring how well the body can take oxygen into the body from the environment, pass that through the different systems down to the skeletal muscles, and how well that skeletal muscle can be used, that oxygen can be used to provide energy at skeletal level, and also the expiration of those byproducts that Todd again very eloquently outlined. Now, traditional definitions is dynamic, essentially looking at the integrated nature of the different systems throughout exercise. And the term non-invasive is used holistically and traditionally, but I actually question whether that is appropriate in the role of assessing chronic conditions, because I actually feel it's an incredibly invasive procedure because of the amount of effort and energy that has to go into that for the participant. And that in itself is a consideration that we need to be very au fait with, and also be okay to be challenged about, and something that I welcome and have welcomed, you know, as part of our group and part of the work that we've been doing. Now, you know, historically and regularly, these are used in clinical settings, you know, whether to determine preoperative assessment or post-intervention assessment, but essentially can be used to look at the functional capacity in an individual, and whether that's done on a 1 day or a 2 day basis. They have lots of use in kind of clinical settings. And it's widely recognised in clinical exercise environments that it offers a significant amount of information that can be used to determine clinical relevance and clinical appropriateness for certain interventions, and also testing, you know, the impact that certain therapeutic interventions might have had for a patient and their symptom profile or their kind of outcomes. So there's lots of different ways that these can be used and have been used and are regularly used in clinical settings to provide some of that prognostic understanding that we need to make informed decisions. So it therefore forms one of those kind of objective assessments that can provide lots of information. Again, Todd's done this very well. This was a kind of a visual description of what a CPET might look like, and I've kind of annotated that with the various pieces of equipment that are required to do that successfully. What I would like to do, and also Todd mentioned the kind of the upright cycle ergometer, is to also mention that there are different modalities, whether that be recumbent cycling, that can also be used to facilitate and deliver tests, you know, of exercise testing, but that has to be factored into the kind of the decision making around appropriateness and also importance of being able to do that. So again, I don't want to kind of tread old ground. I want to use the opportunity to talk about something different, but happy to field any questions around the measurements and what we kind of look for when we're doing those. But we use the expired and inspired gas profiles to look at how well the body can use oxygen and, you know, get rid of those waste products that are produced as a result of exercise, and also the respiratory profile that sits alongside that, because that can give us lots of clues and insight and information that is relevant to determine the kind of the way forward. We can also look at the cardiovascular system and how well that's functioning in response to an external stressor or an external load, and typically do that through heart rate assessments and also ECGs. But then we also need to look more distally at the peripheral systems, at how well that oxygen has transferred from the environment down to the periphery, and how well that can be used to provide exercise. And again, we look at that relative to the external stimuli and stressor that is provided through the body. Now, this might look like a really complicated figure, and even for a clinical exercise physiologist for X amount of years, it's still, you know, takes some kind of thought when we look at it. But essentially what we're doing through this image is actually mapping the journey that the oxygen goes on from inspiration, which is, if I can just hover my cursor over the top left of the figure here, we've got the oxygen that's entering the body at that point from the environment, and the different cogs associate the different systems that are in play when that oxygen is being transferred from the environment down to the skeletal muscle, which is kind of down in the bottom right of the figure, as highlighted there. And all the cogs are different parts of the process. Now, for that to work optimally, those cogs have to work in synchronization with each other and also in that integrated fashion. And often when one of those cogs doesn't work as well or as we expect it to, what will happen is that the performance or the output of the test will start to fall down. And this is where we can use the importance of the cardiopulmonary exercise test to identify where within that pathway there might be a kind of an impairment that might be or kind of associated to a symptom profile. So we can start to investigate with a little bit more insight and detail to be able to do that. And what we've been doing since the kind of, you know, the back end of 2021 is actually starting to think, well, how does this then link to the pathophysiology of long COVID? And this is a picture that I've taken from a paper that we have under review at the moment with various colleagues from around the world who have contributed a huge amount of time to it, documenting and understanding the pathophysiology of long COVID. But what this does is it actually starts to give us an insight into where the different pathologies could be assessed or reviewed by using a traditional approach such as a cardiopulmonary exercise test. But what I'd like to do is just to flick forward a slide, because what I've tried to do here is to annotate this kind of cog network of the different physiologic systems and annotate it to where we think the pathophysiology or the issues or the impairments might lie, to give you a better insight into how we're trying to use this method to unlock some of the mysteries that are associated with the kind of the post-exertional malaise response and the pathophysiology of long COVID. I could spend an hour on this slide, I really could, but I can't because I don't have the time available today. But there's a lot of opportunity for us to start to look at how well the lung is working in terms of the perfusion of oxygen across the membrane into the body. We also have a look at how well the ventilation and the cardiac response at the kind of site of the alveoli is working in terms of the interface of the cardiopulmonary system. We can also assess the kind of the pulmonary venous circuit and how well that's working in response to the preference and the abnormal clotting response that has been readily reported and discussed widely today. And then we can also, as we start to transcend down the different systems, we can start to think about where opportunities might lie. Now, I'm not suggesting for 1 second that this is one single pathology that it will contribute to the kind of the complex chronic conditions of long COVID ME/CFS. I think actually there's an interaction between them, and it's the interactions that cascade down towards the muscular systems that create the bigger and the wider symptom presentation that patients are faced with as a result of the chronic disease. But ultimately what we see is that reduced functional status and quality of life, which has been so widely reported. So to CPAP or not to CPAP, I guess, is the really big question. There's a lot of debate, and rightly so, about whether they're appropriate tools for us to use. And we have to also address that risk versus reward analysis, and that's absolutely essential to how we make decisions around the appropriateness and the clinical relevance of doing these. Now, I can outline the benefits of those, you know, quite coherently, and I think I've already, and Todd previously mentioned some of those that are really, you know, robust justifications for doing them. But the risk is actually, you know, we need to acknowledge the reality of the patients that we're working with and the complexity, and also the potential for harm that is also in that as well. And what I need to, you know, just to reaffirm from previous talks and also to make a point of here is a lot of these tests and the protocols are based on long-standing test criteria. So they've been around, you know, for decades and decades and decades, and they're underpinned by decades of research and insight, but it doesn't acknowledge the novelty or the challenges that are facing patients that are facing more recently in kind of especially the kind of the long COVID sense. And I think we have to take it back to some of the core principles of what's associated with these tests and how well they can be used to inform the design moving forward. So what I've done here, and you know, I'm not going to spend too long on this. Again, I could spend quite a long on this. Is some questions that we could possibly ask about whether we can do CPETs in long COVID patients and ME/CFS patients, whether it's appropriate or not. And maybe these questions could kind of inform that kind of clinical practice around, okay, is this something that we should consider? And next to the question, I've given some context about where that question's kind of come from and how that might be useful in providing a kind of a decision-making tool. And what I kind of want to say, just that conscious of time, acknowledging time, is even if the answer to those questions is yes, we still need to proceed with a level of caution, and extreme caution at that as well. Because what we need to kind of understand is that, the pathophysiology of long COVID ME/CFS is incredibly complex, and we need to give kind of attention and kind of give attention and credit to that when we're making those decisions. And this is what we need to do. I feel it's important, but we need to do it carefully. And I think that the CPETs could provide us with an incredible amount of information that will help us to unlock the mystery and unlock methods moving forward for patients in terms of improving those outcomes, and also in providing insight on how we can provide pharmacological intervention to support in patients. And essentially that is the outcome that we're trying to achieve. How we get to the outcome is the challenge, and the challenge is real, and the challenge is something that we cannot shy away from. And it is absolutely okay to say, we shouldn't do this in this patient for this reason, and we have to take the time and energy that is required to explain that to a patient that is understood. Because from our research, we've had patients who have been desperate to take part in the CPETs that we've conducted, but it hasn't been safe, and we've had to do that in a way and tell them the reasons why we made that decision. So I think testing the pathology, I think CPET's unquestionable relevance in terms of moving the needle forward, but we need to be considerate of post-exertional malaise, which Todd eloquently outlined earlier. So I'm going to breeze through this again, just because I'm conscious of time. And what I want to get to is the fact that we actually have developed a submaximal protocol that negates some of the risks and challenges. It doesn't negate all of them, but it negates some of them. And that provides us with an opportunity to provide additional information and insight that can move the needle forward. So apologies. And that requires a lot of careful planning, not just with post-exertional malaise, but all of the risk factors associated with doing these tests. And we can do that without using those maximal approaches that have been previously described. And it isn't suitable for everyone, but it does provide an opportunity, and an opportunity that I think we should explore as a community of researchers, patients, and clinicians collectively, to see how we can do that well. But it does come, and it has to come, with strict inclusion and test determination criteria that prioritises patient safety and well-being to be able to do that well. So safety is absolutely has to be the first priority, and we operated a kind of a two-step process to determine the appropriateness and safety for patients, reported to their patient-reported outcomes alongside some baseline measures that were determined, a pace that was determined by the patient. And what we developed was an incremental loading protocol over 12 weeks. And we opted for an incremental protocol rather than a ramp protocol, so that we could assess the response over a period of time, rather than having a constantly adding of the workload to the protocol. And we also used the patient's current functional status to determine the starting point and the end point of the test, to make sure that we didn't predispose them to any greater risk. And thankfully, from our test, we did 196 tests. We had one adverse event, and that was one too many, and we were disappointed by that as a team. But upon investigation, we understood that it wasn't because of the test, it was actually because of the screening protocol, and strict measures have been put in place to make sure that doesn't happen again. And we're working at pace to get that protocol published and be able to share that widely, and I'm happy to share that, details of that outside of the talk. Preliminary results. Go on, sorry.
I'm remaining 2 minutes.
Yeah, perfect. Thank you. I think I'm on my penultimate slide. Thanks, Christoph. I can summarise this slide quite easily. There's a lot of information on there, and there is a certain amount, a lot of acronyms and abbreviations that might not mean too much to too many people. And, even though patients are more well-read than me these days, which is phenomenal. But what we're starting to see from the data is that, and something I alluded to earlier, is that within the COGS, or the kind of the integrated systems that present with a cardiopulmonary exercise assessment, is that it isn't one particular system that is dominant or is predominantly causing the issues. It actually starts to appear that there's a multiple effects across the different systems, whether it be respiratory, cardiovascular, or muscular. And I think when we look at them in isolation, it gives us some insight, but what we need to be better at is looking at them and the interdependencies between the systems and how much of an impact further upstream, what does that look like lower downstream, and what's the kind of the net output. And that's what my team are working on incredibly hard at the moment, is to understand the isolated nature, which is important, but also the integrated nature and that interdisciplinarity between the systems and how that might portray or present in a symptom profile for long COVID ME/CFS. So we're working hard, we're working at pace. I'm trying as hard as we can to get that information out there because we needed that information yesterday. But we have to be thorough. We have to do that in a way that is right and does justice to the amount of energy that patients put into the tests for us. And we're hopeful to be able to share some of that information previously. But what it does is it shows us that we're starting to now give evidence to some of the suggested theories about a multi-system and interacting pathology and the broader impacts and the wider impacts that has on the symptom presentation. What we're seeing is that all systems are affected, and we need to look at them in isolation, yes, but we also need to bring them together to have that wider and integrated knowledge, because that is only the true way that we can provide methods and interventions that can improve patient outcomes. We know, we're honest, we know that rehabilitation in its widest definition will be incredibly complex, and to do that we're going to have to use interdisciplinary and personalised approaches, and I'm a big champion of interdisciplinary because it is incredibly different to multidisciplinary, because interdisciplinary suggests that we work together and we integrate our knowledge together around a table, and not in a way that is just focused on my role as a clinical exercise physiologist, but everybody that needs to be around the table is involved, works together to achieve the same outcome. So I don't want it to be confused with multidisciplinary, because they're incredibly different things. And we're honest, we don't know, we don't have all the pieces of information yet. I think this conference has been incredible, highlighting the amount of work that is ongoing, but we're not there yet. We don't have all the information, but I am incredibly confident as a sort of community of patients, academics, and clinicians that we will in time. And yeah, just like to thank you everybody for your support, the collaboration and guidance. I fully believe that we're stronger when we work together. So thank you very much, and hope that's what was well received.
Thank you, Mark Fahey. Brilliant talk. Thank you. So can you handle a few questions? We have a short Q&A.
Of course, yeah. I'll try not to cough too much in between them, but I'll certainly try.
No problem. So Cindy asks, any suggestions for how to prevent further muscle atrophy when we are advised not to exercise when we have ME/CFS and LC? Yeah. I have lost about 10 pounds in muscle over my 2.5-year illness, and this puts me at increased cardiovascular and metabolic risk. I'm a 58-year-old female. Thank you.
Yeah, incredible question. I'm sorry to hear what you've described there. I think it was Cindy, and certainly the case what we're seeing on patients. And essentially, what the challenge is exactly what you've described, is that some exercise is dangerous for some people with long COVID ME/CFS, and therefore engaging in exercise predisposes to a risk. But then you also get the inability to regenerate muscular tissue, and then you end up with the atrophy, and as you described there, I think it was 10 kilos. I think you said, Christoph. And what we need to understand is, and one of the theories we've been postulating as a group, is trying to establish where those thresholds of tolerance are. Could we potentially get to a position where we can give or make a recommendation of, if you can exercise below this intensity, whatever that format might be, that prevents a PEM response but provokes a positive adaptation. Now, I don't know definitively if that's the case, but to do that, we need to know where that threshold of tolerance for exercise and the risks associated with that comes. And for some people, we have to be completely honest, at the severe end of the long COVID ME/CFS spectrum, that is simply getting out of bed and taking a shower for some people, and we have to acknowledge that that is the reality for some people. But for some patients, that might be, there might be some really low intensity or moderate intensity exercises which don't trigger that PEM response, which could then elicit an adaptive response. We just don't know yet, and there's a lot of time and effort kind of going into understanding that threshold of tolerance and what that means in terms of functional activities for patients at the moment. It was Cindy. Sorry, I do apologise.
Okay, thank you. And another one pretty much picks up where that question left. Annette asks, how can we best answer, you are just deconditioned when a cardiologist looks at the results of a one-day CPAP and won't run a day 2. Then they blame all PEM symptoms, etc., and deconditioning and tell me to exercise more.
Yeah, and that's again another question and another comment that we hear an incredible amount with the patients that we see and that we work with. If somebody's not willing or prepared or able to run the second day test, then they can't actually determine the level of deconditioning. As Todd eloquently outlined in his talk, the 2-day test is to identify the post-exertional malaise response and also the kind of the day 2 response. So I'd be certainly pushing for that in terms of giving that additional level of insight and information. I get quite angry and frustrated and emotional because of the patients that I work with and I communicate with on a regular basis in terms of this deconditioning theory, because it's absolute nonsense and it's a cop-out from medical professionals who aren't well read or aren't understanding of the literature that supports that. There's no justification for that use of that phrase. So I find it. My response is probably not audible for an international forum event, but what it would be a lot stronger along the lines of, getting the evidence together, and maybe that's something the academic community can support with, is providing a resource that is accessible for patients to present to their medical professionals as this is what the evidence is, because unfortunately it's just because some people aren't up to speed with the literature and the knowledge, and I only apologize, Annette, that you've had that experience, as so many others have as well.
Thank you. So I think we should wrap up here, if that is okay with you. Thank you, Mark Fahey, for the brilliant talk. Get yourself some rest as well, and I hope you're feeling better soon. All right.
Thank you, Christoph, and thank you, everybody.
Bye-bye.